Hi, my name is Elena Jones. This is a lecture I gave to a master's program for the University of Bluefield in conjunction with BCOM, the institution I work at currently. It's heart external and internal features. For this program, lecturers are given set learning objectives. This is just help to guide the lecturer to know what to instruct in the first place, and also help guide the students that way they know what they're going to be tested on. And so we went through these learning objectives. I probably will not record all of this lecture because it is a 50-minute long lecture, but I'll definitely hit on a lot of these points. Before rolling into this, just a basic warning about the heart. Its shape is kind of funky. It doesn't have a standard left and right when you look at it in anatomical position. It's kind of twisted and contorted, and this can be really confusing. So it's easier to look at it as two muscular pumps that are together. So it is one organ, but it's essentially these two muscular pumps where the left would be the systemic circulating blood through the body, and the right would be the pulmonary, which would be circulating blood from the heart to the lungs. So they're structurally connected, but they're separate pumps. This unique 3D spiral it has is because of embryological development, which we could see here in this diagram, which gives it this weird shape. So the right side is mostly anterior, and the left side is going to be the apex or the point of the heart, and most of the posterior, whereas the atrias, which we'll talk about chambers, are going to be most posterior in the thoracic cavity. So the heart is located within the thorax. More specifically, it's located in the middle mediastinum. This is the broadest part of the inferior mediastinum. So this region here that we see in the blue, let me see if I can get a little laser pointer up. There we go. This region here in the blue is where we see the middle mediastinum. And the heart is located in this sac, and that sac is called the pericardium. And it also kind of surrounds the great vessels around it. This sac has 3 layers. We have the fibrous and serous pericardium. The serous itself has 2 layers, and it has this combined thickness around 1 to 2 millimeters, and this provides the heart with cardiac stability as well as reducing friction, since we do have some serous fluid in that pericardium. So talking more about this fibrous and serous pericardium, the fibrous is this tough connective tissue sac encasing the heart. It's not really attached to the heart, however. It's actually attaching to the adventitia, the great vessels, coming out of the heart and going into the heart, and inferiorly with the central tendon of the diaphragm. So this kind of anchors the heart in the mediastinum. The serous pericardium, if we cut into the fibrous pericardium and reflected it over, we would get to the serous pericardium. And so the layer that is attaching to the fibrous pericardium would be the parietal layer, and then we have the visceral layer, which that would be the layer making contact with the heart. If we look really close, getting into the adventitia or connected to the adventitia, we could see that it is 2 layers. So we see the fibrous pericardium here, and we can see the parietal pericardium, and the serous touching here. So in this space right here, we have the pericardial cavity. This normally holds around 20 to 60 milliliters of serous fluid, and this is what reduces the friction and facilitates smooth heart movement. So I mentioned that pericardial cavity typically holds around 20 to 60 milliliters of serous fluid. In some cases, we can have fluid accumulation. So that is when between the serous and parietal layer, we could see fluid accumulate, whether this is due to inflammation, from cancer, infection, or other immune disorders. On the left, we could see a patient with a normal CT scan, and this space is hardly visible. It's very thin. That is a normal presentation of the pericardial cavity. However, if we look on the right, we can see a patient with pericardial effusion, and we could see the expansion of this region here, indicating that there's fluid accumulating. Other views we could see the right ventricle, the left ventricle, as well as the atrium here, sitting in a more posterior position like I had mentioned previously. In some instances, we can have rapid accumulation of fluid in this pericardial cavity, and this can compress the heart, reduce venous return, and cardiac output, since our pericardial sac is being very compressed, and so our great vessels as well are being compressed. Because we're having reduced venous return, we're going to see descended neck veins because our jugular veins are not going to be able to drain into the superior vena cava. We're going to have hypotension since we have reduced cardio output, and we're also going to have muffled heart sounds because the sound of the heart is not going to travel as well through all this excess fluid. The emergency treatment for this is typically a pericardiocentesis, where they drive a needle into the pericardial sac to drain the fluid, and then usually they'll do some surgery to treat the underlying cause. So I've mentioned these great vessels of the heart quite a few times with reduced cardiac output, talking about how the fibrous pericardium attaches to the adventitia of these great vessels. But what exactly are these great vessels? They're the vessels in which blood is coming to or leaving the heart. And so we have deoxygenated blood entering the heart through the superior inferior vena cava that we could see here. It's superior inferior vena cava. This is a posterior view of the heart, so we can see nice views of both the superior and inferior going into the right atrium there. Then we also have the deoxygenated blood exiting the blood through the pulmonary trunk. And so on the anterior side here, we could see that pulmonary trunk is going to be on this right side of the heart, that weird twisted shape. And so blood will be exiting to go be oxygenated by the lungs, and then we'll have blood returning from the lungs, or oxygenated blood, through the pulmonary veins. This is a nice view to see those. And so those are going to be on the left and right side, draining, or not draining, going into the left atrium. From there, blood will go into the left ventricle and exit out through our last great vessel, which is going to be the aorta, which is supplying blood to all the body. It's fresh and oxygenated. And with that, though, we have our pericardial sinuses. So where we have the great vessels exiting out of the heart, we have kind of these breaks in the pericardial cavity. So it's a feature of the pericardial cavity where it is absent, and so it creates these empty spaces. So two of those spaces we have there are the oblique pericardial sinus, which is going to be just posterior to the heart, right in between the two pulmonary veins. And then we're going to have the transverse pericardial sinus, which kind of separates your output from your inputs. So if you had a glove on and you were in a surgical or cadaveric lab, you could actually entirely without any effort really slide your finger underneath the pulmonary trunk and the aorta, and your superior vena cava would be behind your finger. And so it creates this little tunnel where we can go through because there is no pericardial cavity there. So looking more into these great vessels, we'll start with the aorta. So we'll start with the ascending aorta. So right when it's coming off the heart, that's when it's considered the ascending aorta. And then coming off there, just before it starts arching, we'll have the brachiocephalic trunk, which will be coming off onto the right side here, and then the left subclavian artery, as well as the left common carotid artery. I think my face is currently covering the label for the left common carotid artery, but that would be this one here. And so I like to think of the brachiocephalic trunk as kind of like a little extension, since the aorta leans towards the left side of the body. It's on the left side of the spine. We need kind of a little extension there. So our brachiocephalic trunk serves as that. And then coming off of there, we would have our right common carotid artery and then our right subclavian artery. And then after the arch here, we get into the descending aorta, which would ultimately lead to the thoracic aorta and the abdominal aorta before splitting at the lumbar region for the common iliacs. For our venous structures, we have our superior vena cava here. It's also going to divide. It goes right into the brachiocephalic for both sides, really. So we have two brachiocephalics, left and right, and then coming off each, we have the internal jugular vein, we have the subclavian vein, and then likewise on the right side. So from what I've said and looking at diagrams, you could probably deduce how blood flow would go through the heart. It can really only work one way, but we'll describe it here. So from the upper body, we'll have deoxygenated blood entering the right atrium through the superior vena cava. For the lower body, we're going to have blood entering the heart through the inferior vena cava. So they're going to meet in the right atrium. It's then going to pass through the tricuspid valve and to go into the right ventricle. And then from there, it's going to exit through the pulmonary artery to go to the lungs. On the left side of the heart, the blood's at the lungs, we have to get it back into the heart and into the body. We're going to have, from the lungs, we'll have the pulmonary veins transport the blood to the left atrium. From there, it will go through the bicuspid valve into the left ventricle. It will then enter the arch of the aorta to enter into the body. I've kind of put here, my face again might be in the way of where each of these steps happen. So atrial diastole would be when the atrias relax, and so they're relaxing, allowing blood to enter into the heart. And then atrial systole is when they contract, so they're contracting, squeezing blood into the ventricles, and then ventricular diastole, kind of relaxing, allowing the blood to go into the ventricles, and then ventricular diastole rather is when we would squeeze the ventricles to get it through our outputs being the pulmonary artery and the aorta. Then I usually like to throw in a practice question or two just so the students know how I would ask a question during an exam setting. So this is one about the blood flow through the heart, so hopefully through my lectures they would remember to answer this little clinical vignette. And usually these perform pretty well. But this lecture, like I said, it's a 50-minute long lecture, so I gave in my 11 minutes so you all don't have to watch a full 50 minutes lecture. Thank you so much.